So first, I think the biggest explosion is certainly in the atopic dermatitis space, and we cover that a lot at this point. And I did a separate lecture on atopic dermatitis, so I'll sort of talk about that a little bit separately. The therapeutic update talk is much more for me about new therapies that are non-branded, non-FDA approved, so things that are cheap and easy to use. And so the biggest things for me this year, the single most useful new drug is oral roflumilast. So roflumilast, it's a PDE4 inhibitor. It's FDA approved for COPD, but it went generic last year, and so now it's cheap. So we can get it for about $10 a month if we go through a mail order pharmacy, $15 a month through a regular pharmacy, and that's without insurance coverage. And it is a really potent PDE4 inhibitor that has randomized double-blind placebo-controlled trials showing really good efficacy for psoriasis. So about 50% of people will get to PASI 90, about 70% of people will get to PASI 75. And those are really good numbers for a drug that is extremely safe. So just like a Premolast, which is the same mechanism of action, no immunosuppression, no lab monitoring. About 10% of people will get GI upset. 1% of people will get depressed. But psoriasis is a space that we have so many amazing drugs in already that's actually not the main place I find it useful. So I particularly find it useful for diseases that we don't have high efficacy FDA approved therapies for. So things like lichen planus, oral lichen planus, lichen planopilaris, granuloma annulare, cutaneous connective tissue disease, so cutaneous lupus, cutaneous dermatomyositis, even pyoderma gangrenosum, hinge radenitis suppurativa. Really easy drug to use. Comes as a 500 microgram tablet. You do a half a tablet a day for the first 2 weeks. Then you increase, and that's to give their GI system a chance to get used to it. Then you increase to a whole tablet a day. And I typically give it about 2 months to see how well it is going to work. So that's, if there was one new thing that I could get out there to as many people in dermatology as I could, because for a lot of diseases that we don't have great treatments for, this is a really good, really safe, really simple treatment to use. We still have a significant challenge with acne in the patient in whom topicals aren't getting it, but we don't want to use long-term systemic antibiotics, and for whatever reason, the patient doesn't want to go on isotretinoin, or maybe they've been on isotretinoin before and relapsed. We got a good study this year comparing metformin taken orally to doxycycline, and they were very equivalent in efficacy. It was studied in both men and women. They specifically excluded people with PCOS, and the dosing, 500 milligrams twice a day. Metformin is an incredibly safe drug. So one of the safest drugs that there is. It's an old diabetes drug. It's been around for decades, been used in millions and millions of people. And the things that usually come up with it that people get concerned about that I want to reassure them, it doesn't cause hypoglycemia. And so we don't have to worry that giving it to non-diabetics is going to make them get hypoglycemic. We don't have to worry about metabolic acidosis. That happens at much higher doses. And at higher doses, you also can see some GI upset. You don't see that. So at 500 milligrams twice a day, it's a really good systemic add-on option to our topicals, or to use in combination with spironolactone, which we use for a lot of our hormonally driven acne. So that's another one that's a really good drug that can be useful in a lot of patients. The next one is a couple of diseases that are not terribly common. They're common, but they're not everyday diseases. So acne keloidalis nuchae and pseudofolliculitis barbae. But they're really difficult diseases to treat. And we got a new report this year of using topical, generic, over-the-counter diclofenac. So Voltaren is the branded name, but the generic version of 1% diclofenac is really just as good. It's about $10 for a tube of it. You use it twice a day for 3 months, then you go down to once a day. And I've seen really good results in both acne keloidalis nugae and pseudofolliculitis barbae, both of which can be really difficult to treat. Another useful thing for this year that's a really common thing for nails. So one of the common things that we hear from patients, sort of as an add-on complaint, we finished a skin check, and the patient says, as you're walking out the door, oh, and my nails, they just won't grow. I can't get them to grow like I used to. They break. The first thing I do there now is tell people to stop taking biotin because we know biotin doesn't help. But we have data now to back up using topical minoxidil. So Rogaine is the brand name, but I recommend the generic. So 5% minoxidil, you put a drop on each cuticle every night, and that increases the nail growth rate by about 20%. So it will make the nails grow faster. And then there's a particular keratin called Cyntine HNS, which is Cyntine, and that's an ingredient, not a product. But if you go on Amazon and search Cyntine HNS, it has very good data that it increases nail thickness, increases nail strength, reduces nail breakage. So I do the minoxidil to increase the growth rate, and then I do the Cyntine HNS to make the nails that are growing stronger, thicker, less prone to breakage. So those are probably the biggest, what I would call game-changing therapeutic updates that really give us something new to do in diseases that we have struggled with for a long time. So those, I'd say, were the biggest takeaways from what was new and exciting in the literature this year.